I am now pleased to introduce our first speaker, Tom Morris. Tom serves as the Associate Administrator for Rural Health Policy in the Health Resources and Services Administration of the U.S. Department of Health and Human Services. In this role, he oversees the Office of Rural Health Policy, which administers a range of research and capacity building grant programs that serve rural communities. We're so honored to have him with us today to share HRSA's vision for rural health. Tom?
Hey, thank you very much, and thank NIHCM for hosting this conference and for focusing on rural health. Really appreciate it. With the slides that we'll be using, I'm going to focus a little bit on the federal perspective on rural health, taking a pretty broad view, and then offering a few examples, and then I'll also touch on some of the, setting a context for rural health, and then some of the key issues that we're tracking. So next slide. So I'll start with my office. The Federal Office of Rural Health Policy is located in HRSA, but it has an interesting role in the sense that we're charged in the Social Security Act with advising the Secretary on rural issues, and we have a department-wide focus on rural health issues. But at the same time, we operate a number of programs, as Kate noted, that are around capacity building that very much fit into the fabric of HRSA. And so it's a natural home for us to be there. So we really try to work both across our agency and across HHS and our other governmental partners because, given the challenges we know about in rural communities, we're not going to be able to meet them just with our budget. So one of our approaches is to really work with as many of our partners as we possibly can to leverage more resources on behalf of rural communities. And that's what's great about us being part of HRSA, is because so many of the HRSA programs really do benefit rural communities either directly or indirectly. And so I'm talking about programs like the community health centers, area health education centers, National Service Corps, the home visiting program, just to name a few. But we also have other collaborations going on with the CMS, with CDC, with the National Cancer Institute, and USDA and the rural development programs there. So next slide. So as we think about the federal role in rural health, it sort of takes on a number of different shapes in terms of how it's done. There are obviously a couple of policy levers that are really critical to supporting rural health care. A lot of those are related to payment mechanisms under Medicare. So you'll see special designations under Medicare to take into account the unique challenges rural hospitals have and use the reimbursement methodology in order to make sure that they're open, that they're financially viable, and that they can provide access to care for rural communities. At the same time, CMS, through its Innovation Center, has also had a number of demonstrations and payment models, like one going on right now in Pennsylvania that looks at a global budgeting system, all with an eye towards, what might the future hold and what's the best way to sort of figure out how to finance and support healthcare in rural communities. Similarly, public insurance programs, Medicare, Medicaid, the Children's Health Insurance Program, are critically important in rural communities. And if you look at the patient mix of your average hospital, your average rural health clinic, they're much more dependent on those public payers than they are, say, on private insurance. And so that means any change we make in Medicare or Medicaid or CHIP policy has a disproportionate impact on rural communities. With the advent of the marketplaces and the subsidies that they offer, we've seen increases in insurance and beginning to chip away at the uninsured rate being higher in rural communities. And so all of these are ways that we're going about focusing on increasing access to care in rural communities. But we also know that access, a big part of it is having the workforce there to do it. And this has been a longstanding challenge in rural communities. And so, HRSA funds a number of grants designed to train future doctors, nurses, dentists, you name it, train them to go out and practice in rural and underserved areas. And then we also have loans and scholarship programs that if they agree to take those, they'll practice in an underserved or rural community in exchange for that support. HHS and the states also will sometimes support foreign trained doctors who will practice in an underserved community in exchange for not having to return to their home country. And they play a really important role in terms of ensuring access to care. Now, more broadly, you have block grants like the Preventive Health Services block grant at CDC or the Maternal and Child Health block grant or the Mental Health and Substance Abuse block grants at the Substance Abuse and Mental Health Services Administration. And all of those provide states with tools, and especially for rural states, they can have flexibility to target those resources to areas of greatest need. Sometimes many of those are in rural communities. And so all of those are really important. And then I think as we talk more about social determinants of health, while people won't necessarily think of our programs at the Administration for Children and Families or the Administration for Community Living as key parts of an approach to rural health, the fact is they are. So for ACF, programs like Head Start and the Community Services Block Grant really play a very important role in addressing those social and human service factors that affect access to care. Similarly, the Administration for Community Living, through its support for programs for the elderly and the disabled, like Meals on Wheels, and supporting area agencies on aging, is another way to get at this. And if you move beyond HHS, you have programs like the Department of Labor that does a lot of employment support through both direct training programs and then the one-stop job centers. The housing and urban development also plays a really important role in terms of addressing housing through waivers in rural communities. And then the U.S. Department of Agriculture, the FCC, the Department of Commerce are now, with the American Rescue Plan, administering a significant amount of money to address the broadband gap. So all of this is a long way of saying that the investment in rural health sort of runs the gamut across a range of federal agencies. So next slide. All right, so I mentioned some of those special payment provisions, and I think this map sort of illustrates the impact of those. What you see here is a map of all the community health centers that are in rural communities, the rural health clinics, which is a payment designation under Medicare, and then the critical access hospitals. There are 1,300 critical access hospitals around in this country, and they play an important role in terms of access to care. And they get special reimbursement benefits by being a CAH, which ensures that that access is supported. The community health centers see people regardless of their ability to pay, and 40% of the more than 10,000 community health center service sites are in rural communities. And you add that in with more than just around 4,800 rural health clinics around the country, and they really are the backbone of the safety net in rural communities. Next slide. Now, all this happens in communities where we have fewer practitioners, whether it's physicians or nurse practitioners, physician assistants, oral health providers. The fact is, and long has been, there's just not enough of them out there to really provide care. We have a maldistribution challenge in this country, and the numbers on this slide sort of reflect that. And while we have a number of programs targeted on it, it's not something that is addressed overnight. I am heartened though by a number of new approaches, and I'll mention one real quick. We've been supporting the development of more rural residencies in rural communities through a new grant program we have, because we have data that shows that, particularly for family medicine, you're twice as likely to practice in a rural community if you do your final training in a rural training track. So for the past 3 years, we've been investing in growing the number of rural residencies and taking advantage of some flexibility in the Medicare law that allows new residency programs to be started up in rural communities and not be subject to the cap on Medicare supported rural residencies. We know state Medicaid programs are also doing more in terms of supporting this. So this is one part of a larger strategy, I think, that could help to address these issues. Next slide. Now, the challenges are even more daunting, I think, in terms of access to mental health care, in terms of the number of practitioners out there. We have 250 rural counties in this country that do not have a psychiatrist or a psychologist, a psychiatric nurse practitioner, a licensed clinical social worker, or even a mental health counselor. And so that means the burden falls on top of primary care providers. Unfortunately, sometimes it falls on behalf of the criminal justice system, but it's a really longstanding and challenging situation to address. I am heartened by the fact that of those residency programs I just mentioned, 6 of the ones we've supported so far are for new psychiatric residency programs in rural communities. And the hope is that they can be an important pipeline moving forward. And then a relatively new program in our Bureau of Health Workforce at HRSA, the Behavioral Health Workforce Education and Training Program, or BWET, is also starting to chip away at this also. Next slide. So, given all that, I think most people are aware of some of the challenges that rural communities face, and none of these should be surprising to anybody. But obviously, rural women have higher maternal mortality rates. We have higher rates of chronic disease. We have greater distance to care, particularly for specialty care. All this adds up, to some structural challenges that have been in place for quite some time. Next slide. So given those challenges, it's not a surprise that rural people tend to die at a higher rate of avoidable or excess death in the 5 leading causes of death, whether it's cancer, heart disease, injury, mostly driven by opioids, respiratory disease, and stroke. Next slide. And the mortality gap is interesting. We had a study a couple of years ago that attempted to look at, well, what was driving the gap between it being higher in rural areas relative to urban areas. And what they found was the drivers were virtually the same. It's just that for whatever reason, they're more determinate in rural areas. And so, the challenge is, what do we do about this? I know that when you look at this from a national level, how do you move these metrics? It's very, very challenging. And yet, I know from our own investments in rural communities, very modest investments, that you can empower local towns and areas to address these issues. And last year, we launched a new initiative called Healthy Rural Hometowns, designed around addressing the risk factors associated with those 5 leading causes of death. It's a small step, but we're hopeful that it will show results and that we might be able to then ramp it up more dramatically in the years to come. Next slide. I think we also have this stereotypical vision of rural America as being largely white and elderly. And, there are certainly parts of the country where that is true. And yet, as we think about health equity and equity, we have to realize that there's no monolithic view out here. And the fact is, rural communities are diversifying just like urban communities are, maybe not at the same rate, but they are diversifying. And I think this slide, which is from a Brookings study that was released a few months ago, really details this wonderfully, in the sense that the more yellow you get on these slides, the higher the rate of diversity in the population. And the reason I wanted to mention this is because I think it does factor into how we think about solutions, that we have to think about a more diverse population than we did, say, 10 or 20 years ago. Next slide. So let's talk about some of the challenges that are front and center for us. I think number one, obviously, is the opioid crisis. We know that in the past year, the mortality rate from overdose death has increased. It's increased both in rural and urban areas. The opioid crisis is particularly challenging in smaller communities because they often lack the clinical infrastructure to really deal with it. And then geographic isolation can add to it. And we've been lucky since 2018, we've had a rural community opioids response program, which is giving money directly to communities to create networks of care to address the opioid epidemic. But there's no doubt that during the pandemic, as people in recovery were in isolation, it made it much harder to provide services. So the overdose death rate increase should not be surprising, even as it is disappointing. And so while many of our grantees went to virtual care, it was not a perfect solution for the way to deal with this challenge. And we're hopeful, as we move on to the next phase of the pandemic, that we can get back to continuing to try to turn the tide on this one in particular. Next slide. So we mentioned the impact of the pandemic and COVID-19 at the outset of the presentation, and certainly, it has hit rural communities in a dramatic fashion, and already has been noted, lower vaccination rates, higher case rates, higher mortality, all of which, is a real concern for rural communities. And it's happened at times with less clinical infrastructure, which has overwhelmed many rural hospitals and many rural clinicians. And so, to the administration's credit, when the American Rescue Plan passed, it didn't have anything specifically targeted to rural in the HHS budget, but the administration decided to spend almost $1 billion to support testing and mitigation efforts in rural health clinics and small rural hospitals, to support a vaccine confidence program for rural health clinics. And we also began initiatives to directly distribute vaccines to rural health clinics, community health centers, and to do testing supplies to both of those entities also, as a way to begin addressing some of this. Next slide. Now, Josh will talk a little bit more about this. I won't go into much detail, but I think most people know we've had a rash of rural hospital closures. And the reasons for this are multifaceted. There's no one thing that's driving rural hospitals to close. Part of it is loss of population. Part of it is a challenging payer mix. Some of it may be market consolidation. There's no single solution to this challenge. And we've been tracking it as part of our policy role pretty actively, but particularly since 2010. And during that period, we've had 138 rural hospitals close. So, I think there's no single solution to this one either. And yet, while we have a number of programs to support rural hospitals around quality improvement and performance improvement, we are also tracking closely on a new designation that the Centers for Medicare and Medicaid Services will do rulemaking on this year, to create the Rural Emergency Hospital, which will be basically a rural hospital with no inpatient beds. We don't know what the take-up of this will be, but we suspect that it'll be an important option for communities perhaps that are not big enough to support a full-service hospital, but that need more than a clinic. And so we'll see what happens with this moving forward. Next slide. We're also facing a maternity crisis and an obstetric crisis in many rural communities. More than half of rural counties do not have hospitals that offer obstetric services, and those gaps are particularly pronounced in communities of color. And so you look at this map, the darker the red, the more serious the challenge that we have out there. And again, a number of factors are driving this. We are trying to fund some new projects to get at it. We have the Rural Maternal Obstetrics Management Strategies Program. We began this as a pilot with the idea of working regionally and linking together community health centers, rural hospitals, nurse midwives, Healthy Start grantees, home visiting programs, rural health clinics with upstream tertiaries using telehealth. And we require Medicaid to be part of the network approach that we're using here, with the idea of it being that if we can improve access and we can improve outcomes, we can also save money on the Medicaid side. As we do that, think about it, if you just avoided one neonatal intensive care state unit in a state, you'd basically pay for the entire grant. So we have 6 pilots out right now, and when the budget passes, we'll be moving to have this be a permanent program funded at about $10 million a year. And so we hope that that will help, at least in some communities, begin to address this challenge. Next slide. And then finally, just a quick word about telehealth. I think Josh will cover this in more detail, but obviously, it's always been an important tool in rural communities. What I think we've seen during the pandemic is it's an important tool not just in rural communities, but in many urban communities as well. And reflecting that, the telehealth programs all used to be in my office, but they've since moved to become a standalone office in HRSA. And they really are a focal point for telehealth activity HHS-wide. They led efforts to create a single website point of entry for telehealth issues at HHS, and you can see the address for that webpage on this page. They're also tracking very closely and working with the Department of Commerce on its implementation of a really record amount of money to address the remaining broadband gaps in this country. And so with that, I've included a couple of more slides of interest. Obviously, I've covered a lot of ground in a very short period of time, so please feel free to follow up with me on any of this if you have any other questions. But with that, let me turn it over to Josh. Thank you.
Thank you so much, Tom, for sharing more about the state of rural health in the United States and highlighting some of the key challenges facing rural communities and really sharing the federal approach to reducing disparities and addressing the workforce challenges.